So, who remembers the classification from yesterday?
Yes, supratentorial,
Okay.
posterior
And
fossa, posterior fossa group A, group B,
mm-hmm.
spinal.
Mm-hmm. So there were 4 groups, right?
Subependymoma.
Sorry. Yes, Dr. Yusra. Subependymoma. Yeah, so there
Yes,
were 4 main
subependymoma.
groups. We are going to the slide. I just wanted to see if any of you retained. It's a good thing that you do. So, proceeding, we will start with the radiology again because I think it gets you involved early on. What do you think is going on here, even though the image quality is slightly poor? I'll just give you one hint. This is a T1 post-contrast image, axial sections. So does somebody want to volunteer or should I continue?
Yes. Okay. Should I go?
Yes, Dr. Hussain.
Okay. This is T1 post contrast enhanced lesion occupying the fourth ventricle with extension to the left CB angle.
Yeah, so this is a fourth ventricular lesion, which is showing contrast enhancement. And on the axial sections, we can see that the lesion is extending towards the left, the foramen of Flushka. And this is not exactly CP angle, it is below that, but we see that there is lateral extension. And this is another scan. Can someone else volunteer?
Assalamu alaikum, Dr. Kawal.
Walaikum
Can
assalam,
I
Dr.
do-
Sana.
This is a axial section CT brain plane that is showing a hyper mixed density lesion in the at the level of the fourth ventricle that is occupying it and compressing it towards the right side, and there is a perilesional edema as well that is hypodense,
What
and
else do you see?
there is temporal horn is visible due to the most probably due to upward hydrocephalus.
Yeah, so this is a posterior fossa lesion showing mixed density. You were right about that. What do you think? This is, what is this? Calcification or blood?
Calcification, most probably.
Okay, does this follow the density of the bone? If you look at the surrounding bone, is it just
No,
as hypertense?
no, it's less
Yes,
as compared to
this
bone.
is most likely blood. So this is
Okay.
a hemorrhage within the lesion, and we see significant amount of perilesional edema as well. The fourth ventricle is compressed. It's essentially it's effaced. Anteriorly, we see temporal horn dilatation, which signifies that there is supratentorial hydrocephalus. You were right about that. Never miss hydro on a scan, by the way. Always look in the temporal fossa when you are given a posterior fossa lesion, because the patient is most likely going to have hydrocephalus. Until and unless this is brainstem and early brainstem, they might be the only exception not showing hydrocephalus. Otherwise, posterior fossa patients are going to present to you with hydro most likely. So what do you see here? This is slightly more interesting.
Yes, this is the hemorrhage vein, sagittal cut, showing a mixed intensity lesion at the level of the CP angle.
Is this CP angle?
Would
Would we
at the
say
level
this
of the
is CP?
fourth ventricle, at the level of fourth ventricle.
Okay, and
Fourth ventricle, it is a mixed intensity lesion, showing and also causing hydrocephalus, and there is also a cerebellar tonsils are displaced downwards into the cervical spinal canal.
are you sure
And
this is cerebellar tonsils? I'll
sorry.
show you where the cerebellum is ending roughly. Do you see my cursor? This
Yes,
is the
ma'am. Yes,
rough
ma'am.
margin of where the cerebellum is ending. The lesion is extending below the foramen magnum, at least
Yes,
what
ma'am.
it looks like. It is occupying the foramen magnum, and then it is herniating, in fact, traveling down the foramen magnum, also involving the upper portion of the cervical canal. And a good way to say this is that since this is only one sagittal section, you cannot be sure if this is herniation or if this is lesion. When you're
Yes,
provided
ma'am.
with the limited imaging, always comment that I have very limited imaging. Also, we can't be sure where this is originating from, whether this is originating from the floor of the fourth ventricle or from the hemisphere, or this is coming from the side and also encroaching the midline.
Yes, ma'am.
Moving on, this is another image. What do you see?
This is the flare image.
No, this is T1 post contrast. Do you see the vessels? Vessels are
Yes, ma'am.
always a very good giveaway.
Yes, ma'am. T1 with contrast.
Yes, this is T1 post contrast.
This is the axial cut of the brain, showing the base of the brain and the lesion at the level of the fourth ventricle, which is the uh, patchy contrast enhancement
Good.
due to the thing did not take the contrast. It may be the cyst or necrosis.
Yes. So what do we call this kind of lesions? We call them solid cystic lesions.
Solid cystic.
Yes, these are solid cystic well circumscribed lesion in the fourth ventricle. I am not sure where this is arising from. This can arise from the floor of the fourth ventricle. It can also arise from the lateral, if you see cerebral peduncles, cerebellar peduncles. And this is effacing the fourth ventricle, but not completely obscuring it. The lesion is showing some cystic components in between and patchy contrast enhancement. And this looks like well circumscribed. So, moving on to the also one of the temporal horns is dilated, the other one is not. So you don't know if the scan was taken in an oblique position, because you see one orbit is small, the other one is larger. So there might be a difference of section. So you can say that I see one temporal horn dilated. I'm not sure about the other one. I would like to see further imaging to see if there is supratentorial hydrocephalus. So this is the same lesion on T2 weighted images. You see that there is some cystic component in the middle, which is following the intensity of CSF around. And yes, we clearly see temporal horns. And look at the beautiful view of MCA. It looks really beautiful. So, what do you see here? Where is the lesion?
At the level of the fourth ventricle.
No. Even better. If you had to say it better, what would you say? It's foramen magnum.
Yes, sir.
See, if you look it up close, the lesion, just give me a minute. The lesion is here. What you confused as, I think you confused this as the lesion, right? If you see my
Yes, sir.
cursor, I think you confused this. This was part of the cerebellum. This is where the lesion is. And if you're not careful in terms of how you're approaching it, it might be mistaken for Chiari malformation as well, looking as if this is herniation. So if somebody gets this image and does not get a contrast image, this might be missed completely, because let me show you the next image. This is exactly at the level of foramen magnum. It's not a very typical location for posterior fossa ependymomas. We know that they arise in the fourth ventricle, but this is foramen of Magendie, and it is traversing the foramen of magnum, coming down, and might mimic the cerebellar tonsillar herniation on T1 weighted images if one is not careful. Also looks to be very well circumscribed, and these are post-contrast images showing homogeneous uptake, intense enhancement, and homogeneous uptake of the contrast. And interestingly, patient has not developed hydrocephalus in this case. If you see, probably because some form of CSF communication is intact. So moving on, I think this did wake up your brains. Radiology is always the best part. For me, at least it is. I like it. I don't know how many of you like it, but I think it's beautiful to see brain in such a visual manner without actually opening it up. So just a very quick review. Yesterday, I am going to show you this chart again and again till we are doing ependymomas so that you people ratify this entire classification. And when you go back and read whatever textbook you are reading, it's a lot easier. Supratentorial ependymomas, we have posterior fossa ependymomas, we have spinal ependymomas, and we have subependymoma. The first three categories can be grade 2 or grade 3. The last category is a grade 1. Okay, mixo is grade 2. Rest of them can be either grade 2 or grade 3. Supratentorial were divided into 2, and whatever the leftover was, it was piled in this group, NOS and NEC, not elsewhere classified. So supratentorial were classified in ZEFTA and GAP1 fusion positive. Posterior fossa were very easy to classify, group A and group B. Spinal ependymomas have two main variants. The first is classic. The second is Mycian amplified. Since it is Mycian amplified, it is assumed to be an aggressive tumor. Myxopapillary ependymoma, which was formerly grade 1, now it is grade 2. And subependymoma, which is grade 1, completely indolent benign lesion. Moving on, we have posterior fossa ependymomas today. So there were a few things that I wanted to discuss today. One of them is the clarification. All ependymomas do not arise from the floor of the fourth ventricle. Anybody who has read Greenberg would be very clear about it, but it is one of the most common things that we hear during our rounds, that medulloblastomas arise from the roof, ependymomas arise from the floor. Yes, that is general rule, but it does not always follow it. Okay, so the posterior fossa ependymomas can originate in relation with fourth ventricle, can be in the midline, can be the floor, can be the lateral recess. I have given you plenty of examples to see the lateral recess extension. Can be from the roof as well, sometimes from the cerebellar peduncles as well. So they might present with hydrocephalus and cranial of 6th and 7th palsies. Can somebody tell me why 6 and 7 palsies and not others?
Because, ma'am, facial colliculus, there is a visible bump at the floor of the fourth ventricle, which is formed by the motor fibers of the facial nerve around the abducent nerve nucleus. Therefore, there is a visible bump at the floor of the fourth ventricle, facial colliculus. And when ependymoma arises from the floor, it definitely affects the facial colliculus, and 6 and 7 palsies are occurring.
That's brilliant. So the patient is going to present with diplopia and facial weakness, right? So
Yes, ma'am.
there is going to be a very typical presentation, hydro, and you will have cranial nerve palsies. If the lesion is big enough, it might later on involve the lower cranial nerve palsies, but they are not common, right? At least at the presentation. The younger the patient, the worse the prognosis. This is the norm for ependymomas. And what I wanted to emphasize was that histopathological grading of ependymomas is not correlated with the overall outcome. And I think we have cleared this concept again and again during all these Zoom sessions. Also, based on my personal experience with the patients presenting with posterior fossa tumors, a very common and often missed OPT presentation is that a parent will come to you and they will let you know that their child keeps falling again and again, because these patients might have ataxia, they might have poor balance. What ends up happening is when they're playing with other kids, they can have repetitive falls. And that might be the first presentation before they even develop hydrocephalus or cranial nerve palsies. A lot of patients that I have seen have only presented with mild headache and repetitive episodes of falls. So, symptoms of raised ICP: headache, vomiting, we all know that. And early morning, especially, patient might report vertigo, ataxia, lethargy. There might be altered level of consciousness if they are presenting late enough, depending on the setup you are working in, and awareness of the patient as well, and the attendant, obviously. If the sutures are open, younger age group, 1 year infants, something. So where there you can have increasing OFC as well. So we already know that posterior fossa ependymomas are divided into two groups, group A and group B. Are you all with me, or do I need to slow down?
Yes,
Yes,
ma'am.
ma'am.
Yes.
Okay, moving on. They can be grade 2, grade 3 based on anaplasia. Necrosis does not play as strong of a role in ependymoma grading, but the proliferation, microvascular proliferation, and cellular atypia might have some role. They can arise from roof or lateral aspect of fourth ventricle. Now, if you remember it in the form of a comparison, it would be easier. Group A can arise from roof or lateral aspect. Group B usually arises from floor. Group A's median age is 3 years. And Group B has a median age which is later. And the prognosis is poorer when we are talking about Group A. Extent of resection is the main prognosticator, and this stands true for both Group A and Group B. Am I clear?
Yes, Dr. Qambrani.
Okay, so just a quick review. Roof or lateral aspect is more common for posterior fossa group A tumors. Median age is a lot younger, 3 years. Prognosis is poorer. If we see group B tumors, again, they can be grade 2 or grade 3. That stands true for both of them, but they arise more frequently from the floor of fourth ventricle. Also, they are more common in adults and adolescents. Median age is 30 years. For me, it's easier to remember that one is 3 and the other is 30. And because of 3 and 30, I think there was this movie, 13 going on 30. So this is 3 going on 30. Posterior fossa A is 3 years. Posterior fossa B is 30 years. Moving on. This is the goal of surgery. I am clear. Have I made myself clear, or do I need to go back?
Clear.
Yes, ma'am.
Yeah,
Clear.
ependymomas are very straightforward. They are beautiful tumors, and they are also very easy to remember as well. So, goal of surgery is maximum safe resection. We already know that. What is the goal? Since they are adherent to they are adherent to the floor of the fourth ventricle. Sometimes there might even be invasion. GTR might not be a realistic option, especially any of you who have assisted in the surgeries, they would know that patient can very quickly develop bradycardia, and your anesthetist might give you back off and call the surgery off. You need to leave the residual there, and the realistic option is usually maximum safe resection. So, GTR is also very difficult if the lesion has traversed through the foramen of Lishka, and in rare cases through foramen of Majundi, which we saw. 2 weeks post-op in your patient, you are going to go for lumbar puncture for CSF cytology. I have written the reason why. I did not discuss it before, assuming that it's common knowledge, but ependymomas can also cause drop mets. What are drop mets? They are leptomeningeal seedlings. So, how are you going to rule these out? We have two options. Preoperatively, we can get the craniospinal imaging with contrast. That's one option. The second option is to get LP for CSF cytology 2 weeks postoperatively. The buzzword here is 2 weeks, right? What ends up happening is, if the imaging is negative, it does not show any drop mets, but the CSF cytology is showing the tumor cells, then this means the patient is positive for drop mets. CSF cytology will rule out negative imaging any day. And yes, I know that a lot of us don't have CSF cytology available here. I don't think it is available in any setup in Pakistan. I'm not sure about AKU. We have had these discussions during the PNO tumor boards there, but I think can someone else correlate with me on this? Do we have CSF cytology available anywhere in Pakistan? People who are working in different setups?
No, Dr. Kanwal.
Yeah, I think it's not. I can ask a few people. That might mean that a lot of patients who we are treating as patients without drop mets because their imaging was negative might actually be positive for drop mets because we have not done the CSF cytology, which is a lot more specific. So these are what the current recommendations are. A lot to look at, but this would be easier if you can go back after the session and look at the PPT itself. I will upload it today and the yesterday's PPT as well. So the GTR is, if GTR has been done, if the patient was lucky enough and it was a well-circumscribed tumor without much invasion or infiltration, and the surgeon was able to go through the complete resection, even then, adjuvant local radiation therapy is a standard. Ependymoma comes with local radiation therapy. That's the bare minimum. If it was an STR, subtotal resection, then you will have to give local radiation therapy, and boost may be used for the residual areas. If it is metastatic disease, which is when drop mets are positive or CSF cytology is positive. If either of these situations is positive, then craniospinal radiation would be given. If the patient is younger than 3 years, ideally, I have written 12 to 18, that's the median age group. Ideally, we avoid radiotherapy in any patient under 3 years. Why? Because it can significantly damage the developing brain and cause long-lasting neurocognitive effects. So chemotherapy is often used as a temporizing measure here. Am I clear?
Yes, ma'am.
Yes.
Okay.
Yes.
Somebody has written something in the chat. A for adolescents, A for apex. Yes, that is a very good way to remember. Okay. Cranial radiotherapy. Traditional therapy is 45 to 48 grays. If there's recurrence, we can give additional 15 to 20 grays. And there are some setups available here which are offering the 3D radiotherapy. With 3D, the benefit is that you can give higher doses, roughly 59.4 grays, which are delivered to the tumor bed along with 1 centimeter normal margin. Spinal radiotherapy is given when patient is positive for drop mets, as I already mentioned, or if CSF cytology is positive. The entire spinal axis is given low-dose radiotherapy, which is 30 grays, and boost is given to any regions which are showing drop mets. And as I have already mentioned, radiotherapy is avoided under the age of 3. Chemotherapy has a limited and temporizing role. The ependymomas are very radiosensitive. They are not as sensitive to chemotherapy, so the role is very limited. And that's a wrap. So any feedback, any questions, they are welcome. If you don't want to turn on your mic, you can leave the questions in chat as well or on the group. Any
Thank you, ma'am.
questions?
Thank you, ma'am. Wonderful. Thanks.
Okay. We have one message in the chat. Thank you. Okay, that's just a thank you.
I have a little question, please.
Yes, Dr. Kingsley.
Okay, thank you very much for the nice presentation. I want to ask, is there any reason for keeping the CSF analysis, the cytology, about 2 weeks post-op? And then given you operated with the posterior fossa, probably you had a subtotal resection. Are there precautions you have to take before you do the lumbar puncture for the CSF?
Okay, Dr. Kingsley, if I can reframe your question, I think you're asking that why we are insisting on 2 weeks and not earlier, right?
Yes, exactly.
Okay, so that is because when we are operating on posterior fossa, there might be blood, and that blood might trickle down and travel down the spinal canal. And when we take out a sample, the sample might be polluted with the reactive cytology. Because if there is blood in the CSF, that is an irritant, it's going to increase the production of protein. I think you already know the concept of aseptic meningitis, which is what happens when there is blood in the CSF, right? Because it is a chemical irritant. So 2 weeks is a sufficient time to clear that off, and the sample that we get is a lot more accurate.
All right, thank you.
Okay, everyone, this is a wrap. Thank you for joining.
Thank you.